talk about his case now.
Okay. For a phaco surgeon, dealing with hard cataracts is still an uphill task and is fraught with complications like wound burn, endothelial damage and PCR. Hence, phaco surgeons are shifting from the classical 4-quadrant cracking method to direct chopping techniques. Of late, FLACS, that is the femtolaser assisted cataract surgery, being an extremely expensive option. Therefore, pre-chopping the endonucleus is still a cheap and viable option for us to reduce the collateral damaging potentials of phaco energy. We in this video presents a newly designed pre-chopper well suited for all grades of cataract, especially the harder ones. Pre-chopper goes through 2.8 mm incision and the left hand uses a Chang chopper to hook the equator of the endonucleus in all these videos. This is a second video demonstrating the intumescent cataract wherein the surgeon is aspirating a liquid cortex with the help of 26 number needle, capsular X is being completed and pre-chopping being attempted. The entire endonucleus now is divided into two endonuclei, heminuclei I mean to say, and after rotation again the pre-chopper is dividing a heminuclei into two fragments. Phacoemulsification is now being carried to empty the capsular bag of the nuclear fragment. In this third video, we are demonstrating a dense nuclear cataract being pre-chopped with the help of this new pre-chopper. The endonucleus being hooked, the pre-chopper is dividing the endonucleus into two halves. This is a viscoelastic dependent technique, and what you need to appreciate is that the fragments which are produced are almost imitating the fragments which are produced by femtolaser. They are very steep, they have a very steep borders. This pre-chopper is also very helpful for dealing with a soft cataract, which at times can produce a cheese wiring when you are using a high vacuum and phaco energy. This elegant pre-chopper is therefore well suited for all varieties of hard as well as soft cataract. Being sleek, the anterior chamber is well maintained and this is compatible with 2.2 and 2.8 mm incision. It doesn't resemble any cross-section forceps like a classical Akahoshi pre-chop forceps. The learning curve is not very steep and is definitely very easy to master. This is the last video of this video presentation where the capsular excess was lost because of the high intralenticular pressure in a intumescent cataract. The end result was a disastrous Argentinian flag sign, and to proceed or not is always in the back of a mind because we don't want to confront a catastrophe like a nucleus drop during phacoemulsification when the capsular excess is lost. These capsular flaps, the irregularly torn flaps, are converted into what we can call it as a pseudo capsular excess, and because the pre-chopper is dividing the nucleus, the other pole of the nucleus being hooked by the Chang chopper, the energy is against each other, and therefore this becomes a very safe option for the phaco surgeon to divide the nucleus. So even in loose zonules and where the capsular integrity is not 100%, we can do a phenomenal nice pre-chop. Thank you. Thank you very much.
Thank you very much.
So Sohel, first thing, I think there are two questions. One is from the audience and a lot of questions from the panel. The audience wants to know, where did you make this and who's making it, where do we buy it from? Panel wants to ask a few questions on some of the safety options, probably
As
how
far as
sharp
the
it is and stuff.
audience question is concerned, it's not available commercially. It is. It has evolved through almost 1.5 years of research and modifications. Yeah.
I think it was an excellent innovative chopper.
Very good.
I have seen till date. This is excellent and it is very cost effective, whatever. I think it will be ultimately cost
Manual
effective.
femto.
And we should not undermine the innovations and the skill of the surgeon.
Absolutely.
I appreciate him highly.
Thank you very much, sir. Thank you.
I think Dr. Sohel, you need to be congratulated for that,
Thank you, sir.
number one. And I think with the incision size, that needs to be titrated because because the chamber would become unstable. So that needs to be worked on. And
Yeah. Actually, I have used a very hydroxypropyl methyl cellulose rather than using anything like a Hilon GV or a Viscoat. So I have used
it has to be calibrated. If
So
you
that
can.
could have, I would say, made my life a little more easier.
Yeah.
But
And
definitely,
with the Argentinian flag sign,
yeah.
with the chamber not being stable with the manipulations, that would have jeopardized the capsular tear to a wraparound tear. So
Yeah,
that-
definitely. I'm not recommending this as a technique, but because I have tried and I had a little bit of a confidence that I should try, I have ended up producing 10 Argentinian flag sign and I have not succumbed to a complication like a nucleus drop and something. I'm not recommending this to a general audience, or even I may be a little scared to attempt a furthermore, but nonetheless I have found this maneuver because the nucleus is wedged against these two forces, and therefore the liability that your tear may further extending and producing a PCR and a nucleus drop is.
Dr. Shin, you want to say something?
I think it's a nice and elegant technique. So I had some experience in the past trying to use two choppers to chop the nucleus. What I had is always you have to conquer the rotational movement, because as far as these two instruments are not going directly to each other, there is a rotational movement.
Torsion,
and
yes,
my question to you: how do you counteract this? Any tips on how to avoid this rotational movement?
Actually, two
in
things
your
are happening with a hard cataract. One is the, I mean, say, when I'm using these two instruments against each other, there's a little bit of torsion, as you have nicely explained, that I'm sensing that kind of torsion. But at the end of that, if I'm little jerky, I may end up producing a complication. So as I'm crossing my equator, I'm little slowing down, so that as I'm approaching the Chang chopper, I'm little slowing down. And secondly, it does happen that in the course of time, the entire endonucleus lifts up in the capsular bag. So that also give me a little bit of, what you can say, an ability to get away with that amount of torsion.
Dr. Millens?
So I have a couple of, first of all, congratulations.
Thank
I think
you, sir.
that's a great technique. What is the actual dimension of the chopper? How tall is it?
It's almost 1.6 millimeter.
1.6 millimeter. It
Yeah.
has a curve on it,
Yeah.
so that'll adjust for a little. So I saw from your videos the Rexus sizes you were using were on the larger side.
Yes,
What's the smallest Rexus you could use this with, you think?
To make the maneuver easy, because we are dealing with hard cataract. So naturally, as a Indian person who has been trained for SICS, that is a priority. Like if I end up producing a complication, I should be able to convert. And the best thing that can help me is having a large size Rexus.
Okay.
Like I err on doing a little larger Rexus rather than a classical 5.5 millimeter Rexus and then having a complication. So
The next question comes, do you think you could use this chopper with a 5 millimeter Rexus?
It will require a little bit of expertise, and moreover, one of the steps which I have not demonstrated is I am making it compulsorily essential to aspirate a little bit of cortex and epinucleus over the surface of the, as soon as I do my hydrodissection, I make it sure that I aspirate a little bit of chunk of the tissue so that I get a little purchase into the endonucleus with my Chang chopper. So that creates a little bit of space.
Is your chopper sharp enough to go through the nucleus vertically?
It is very sharp, sir. It's very
So
sharp.
it'll go through vertically, straight through anywhere?
And yeah, but my
Or
direction
do you
of
have
impact.
to start it from the edge
Yeah,
of the nucleus?
direction of the impact is not directed posteriorly, it is obliquely. So I've never had in all these, say for example, 900 surgeries, I've never ended up producing a PCR. Nonetheless, I have hooked the intercapsular margin and produced a zonular dialysis. That is true, as can happen with any horizontal chopping surgeon. But producing a catastrophe like PCR, I have never encountered.
And have you tried the MyLoop at all?
My loop, I don't have an
It's
access
a similar
to.
principle, but done in a different way.
Yes.
Thank you.
Thank you,
Sohel.
sir.
So after that interesting video, we have now